Good afternoon. That better. Well, welcome. Welcome to the 22nd B. Frank Polk Lectureship. I'm Dick Chason from the Center for AIDS Research at Johns Hopkins. I'd like to welcome you to this event, which is part of the annual scientific meeting of the Johns Hopkins CFAR. I'd like to begin by acknowledging Genevieve Polk, Frank's daughter, who is here with us today. Thanks very much for coming. I think everyone in this room and probably almost everyone in this city is familiar with Frank Polk and Frank Polk's amazing contributions to HIV/AIDS, Johns Hopkins, and to public health. Frank was a professor in the Department of Epidemiology through his untimely death in 1988. And his legacy is just spectacular. This is a list of some of the things that Frank accomplished in his time here at Johns Hopkins, including the establishment of the multi-center AIDS cohort study, the ALIVE study, the FACS study, and I think I remember that FACS is the frequency of agents communicated through transfusion studies, but Frank always had great acronyms. Studies of HIV in the state prisons, HIV in Malawi, which has gone on to become a longstanding clinical trial site in Malawi with a Johns Hopkins building in Blantyre. He started the Fogarty ATERP program, which trained ultimately thousands of people from more than 20 countries in HIV research. The ID-EPI program here at the Bloomberg School, the Polk Family Assistant Professorship in Epidemiology, which I'll mention more in a moment. He started the Johns Hopkins HIV Clinic, known to most as the Moore Clinic, and he started the inpatient HIV unit, now called the Polk unit, at the Johns Hopkins Hospital. So just an extraordinary legacy. And if you look at the characters he worked with, this is a little bit like that picture of Bill Gates in 1974 with the question, would you have invested? Would you have expected? And maybe you wouldn't have expected, but what has come out of his work and his legacy is truly phenomenal. And I mentioned the Polk Family Assistant Professorship in Infectious Disease Epidemiology, and its first awardee, David Dowdy. And this is in honor of both Frank and Kathleen Polk, the late Kathleen Polk, Frank's wife. And this is David Celentano and David with Sarah Polk, who is a pediatrician at Bayview, but who's spending her day flying to Italy instead of being able to be with us today. But this is a legacy that invests in young investigators, not old established ones, and creates a funding opportunity to allow a promising new investigator to get off to a good start. And it's a truly unique program. It's the only endowed assistant professorship that I've ever heard of. So very, very important part of the legacy. So importantly, the Polk Lecture began under Frank's leadership and then continued with being named in his honor and memory. And I'm really pleased with this year's Polk Lecturer, Susan Buchbinder. Susan is the director of the Bridge HIV Department in the San Francisco Department of Public Health. I'm really never sure what the Bridge is, but maybe you'll tell us. And she's also a professor of medicine at the University of California, San Francisco. I had the pleasure and joy of working with her when she was a medical student and watched her rise through the ranks of medical school, internship, residency, and then go on to a really spectacular career as an HIV researcher, based primarily at the San Francisco Department of Health for the past 25 plus years, where she works on HIV prevention, PrEP, understanding risk behaviors, and very importantly on HIV vaccines. and plays a leadership role in the HIV vaccine trials network, as well as the HIV prevention trials network and many other networks. So it's a great pleasure to have Susan come from the city by the bay to our city by the bay and share with us her perspectives on controlling HIV in the future. And I actually don't have the title of your talk in front of me, but we all will in a moment. So please join me in welcoming Susan Buchbinder as this year's Polk Lecturer.
Well, thank you for that really lovely introduction. And Dick did ask me what the title of the talk was, but I couldn't remember, so we figured we'd see it when it came up. And I really appreciate the invitation to speak today, particularly in honor of Frank Polk, who was one of the early pioneers in helping us to learn about HIV, how it was transmitted, what risk factors were, and really what the outcomes were. And that was very important to me because I came to San Francisco in 1980. And I remember in 1981 hearing a professor come in and say we were seeing new unusual cancers in gay men. And so my whole medical career was really growing up in the HIV epidemic. I don't know if you would trust this man, invest in this man either, which as you get closer, you could see that this is actually Dick Chason with Molly Cook looking at him, and he kindly provided the picture. It's a little blurry, but I was fortunate to learn from the great epidemiologists about the HIV epidemic and from the great clinicians, because I was Dick's third year medical student, fourth year medical student, and intern. So the question is really, how do we stop the epidemic? Now that we've got this really highly effective prevention that we can use to both in terms of treatment and prevention, and we've got this opportunity for synergy, how is it that we stop the epidemic here in the United States? So I'm going to talk about it across the country, and then I'm also going to talk a little bit about what we're trying to do in San Francisco. So this is the framework that I use to kind of think about it. We need to have the right population. We need to know where the infections are happening. Effective interventions, the question is not just efficacy, but is this going to actually work in real-world settings? That's the effectiveness. Scale up, can we actually reach enough of the population to make a difference? Because it's great if we've got a very highly effective intervention, but if nobody wants it, then that's not going to really help us. So that's about coverage. Desirability, will people start it and then continue to use it? So that's both adherence and persistence. And then I'm going to talk very briefly about what the future may hold in terms of new approaches to HIV prevention. So epidemiology, effectiveness, coverage, adherence and persistence, and new agents and formulations. And I'm going to summarize at the end of each of these intervals. So the epidemiology, trends in the United States, and I'm sure that many of you are aware of this, but men who have sex with men is the only group that continues to have an increase in new HIV diagnoses and are the most heavily impacted population. You can see that among men who have sex with men, it's the 13 to 34-year-olds who also still have rising numbers of new diagnoses and the ones most heavily impacted. Now, if you look at the 13 to 24-year-olds and you look by race, this is diagnosis number. This isn't even proportion. So this is clearly well out of proportion with the background demographics of the population. Black or African American men who have sex with men are at substantially increased risk. And Hispanic or Latino men are also at substantial risk, out of proportion with their size within the general population. If we put it all together, men who have sex with men, age, and race ethnicity, just to show you the patterns, the 13 to 24-year-old Black MSM, this is the total number of new HIV diagnoses in 2014 across the country. And that's criminal as far as I'm concerned, that we're not doing more to take care of this epidemic and to provide services. And you can see that within these younger age groups, Black or African American men have the highest number of new infections. Hispanic or Latino are second. And even in situations where those numbers are lower than in white men, it's still out of proportion with the size of the population. So I'm going to tell you a little bit about what we're trying to do in San Francisco, which is, we call it getting to zero. We don't call it ending AIDS because our community that's living with HIV feels like that means, oh, so if you just get rid of us, that's how you're going to have to get rid of AIDS. So we call it getting to zero, zero new HIV infections, zero deaths, and zero stigma and discrimination. Let me just see, did I miss something? I did miss something, okay. Before I go to what we're doing, lifetime risk of HIV infection by state across the country. So there are these geographic issues, and you can see that the South is among the most heavily impacted region of the country. It's also where Medicaid expansion is least likely to occur. So it's also where the death rates are highest. But I just want to point out, I was very surprised. I knew that this is if nothing were to happen. The lifetime risk of becoming HIV infected was 1 in 13 in Washington, D.C. The second highest rate, 1 in 49 in Maryland. So not something to cheer about, but something that I know that all of you are working very hard to reverse. So going to San Francisco now. We've been fortunate in driving down our new infections, and it looks like we're going to be about half of what we were in 2006 and 2015. So over the last decade, we have the number of new infections. We also have a decrease in the number of deaths, and obviously then an increase in the number of people living with HIV. We have a very different epidemic in San Francisco than you have in Baltimore. It's predominantly in men who have sex with men. 86% are either men who have sex with men or men who have sex with men who also inject drugs. 6% are in people who inject drugs. We only had 20 diagnoses in women in 2016. 14 of those were in cis women and 6 were in trans women. So we have a very concentrated epidemic in our MSM population, and much less so in the female population or in people who inject drugs. We do, though, unfortunately, share the disparities that we see across the country. So you can see that we're doing better in terms of the total number of new diagnoses, decreasing significantly in both white and black populations in San Francisco. But these are the annual rates among men in San Francisco per 100,000 population, and you can see that in black men across the board, we have twice the rate that we have in women, and twice the rate that we have in white men, and it's also elevated in Latino men. So we're also trying to get rid of HIV-associated deaths, and we say HIV-associated deaths because while we would like to make people living with HIV immortal, we know that we can't take away all deaths, but we do look at HIV-associated deaths, and you can see that that's been on steady decline for the most part, whereas the non-HIV deaths is staying pretty level. I've had the challenge of looking through death certificates over the last 5 years for all people who are San Francisco cases, and it's very challenging. And what we find is that there's actually an increase in drug overdoses and an increase in suicides, which is pointing to, we have this national epidemic of overdoses. This doesn't even include the people who are dying from stimulant use and having aneurysms that blow and other kinds of consequences from stimulant use. So the summary, and when we think about what populations do we need to reach, I'm focused mostly on MSM because they are the population in San Francisco. Clearly there's an epidemic in women as well, but MSM are the ones in whom the new diagnoses are increasing. And we've got these disparities by race, ethnicity, by age, by geography that we need to address. We do need to pay attention to all risk groups because we're still seeing new diagnoses in the over 50 group. Some of those are people who were previously undiagnosed who became infected earlier on, but some of them are getting newly infected. So we don't want to forget that, but youth have some particular vulnerabilities. And identifying the cause of death is actually quite challenging because there often is very little written on the death certificate, but it is actually very important, and we are it really is pointing to the need for substance use treatment in mental health. So let's talk about antiretrovirals, which are so effective now, weren't there in the early years of the epidemic, and we have the ability both to lower new infections by treatment and by pre-exposure prophylaxis. So this is the infamous HPTN-052 study, over 1,700 serodiscordant couples in Africa. 97% of them were heterosexual, and the one partner's positive, one partner's negative. The positive partner was randomized to either receive antiretroviral therapy at that time early, when the CD4 count was still over 350, or waiting until whatever the standard of care was in that community, and that changed over time, as did then the time for initiation of treatment. And what you'll remember is that there was 96% protection in that study. There were 28 linked infections, only one in the person who was randomized to immediate ART. The immediate ART person had just recently started ART. I do want to point out that in virtually every study that I see and in patients with whom I speak, a quarter to a third of the serodiscordant couples are getting infected from outside of the partnership. So when you're talking to people about their potential risk and they've got a positive partner and they say, the positive partner's fully virally suppressed, you still need to ask if they've got other partners because they can get infected outside of that partnership. So I'm going to talk about, that's the ideal world, 96% reduction in a clinical trial. What's happening in the real world? So in 2015, data was presented for the first time on serodiscordant MSM couples, and they've seen no new infections in these serodiscordant men who have sex with men couples where one's positive, one's negative. We've got to remember that it's still early. This was an interim analysis. The upper bound of the confidence interval was 4%, so it could be as high as 4%. So we don't know that it's zero. It's good news, but we have to take it with a grain of salt, and as high as 6.5% if they were engaging in receptive anal sex, if the negative partner was the bottom. Data, very important data from the Partners Prep study in serodiscordant heterosexual couples. It took 6 months for the risk to go away. So we also have to remember that it may take time for people to fully virally suppress, particularly in genital secretions, and that's something to take into account. And then I thought this was another important study from CROI 2015 in which over 14,000 patients who were actually in clinics, in 6 clinics in the United States. So these are people in care. This doesn't even address the people who are out of care. And more than half had viral loads of greater than 1,500. And Tom Quinn, who's here, was the lead author on that really landmark paper looking at the role of viral load and the association of viral load with the risk of HIV transmission. And a quarter of the time of follow-up, any given patient, 23% of the time of follow-up of these 14,000 patients, the viral load was high enough that transmission could occur. So again, when talking to people, a lot of people say, oh, but I'm fully virally suppressed, so I can't transmit, but the guy told me he was fully virally suppressed. And we just have to be careful to know for how long, and is it consistent? So if we ask where are the new infections coming from, this is a modeling study from the CDC. Jacek Skarbinski, who also trained at San Francisco General Hospital, is the lead author on this. And you can see that about 1/3 of the new infections are from the undiagnosed population, but about 2/3 are from those who are not retained in care. So that's a very important population that we need to be reaching out to. So let's take a look then at the other side of the equation, which is pre-exposure prophylaxis and other prevention strategies. And this is a slide from the AIDS Vaccine Advocacy Coalition. And you can't see this in detail, but all you need to know is that the pink are different kinds of pre-exposure prophylaxis or antiretroviral use. These two are vaginal rings. This is the lone vaccine study. I'll talk about it at the end. This is the line above which there was significant reduction in new infections. But you can see that at the top of the list, PROUD, IPERGAY, and Partners PrEP had between a 75% and 86% reduction in new infections, so almost as good as the treatment side of things. And Proud in particular was being conducted within the context of busy STD clinics in which there wasn't any really additional counseling and other kinds of, it was just whatever the usual care was. This was a feasibility study to either start PrEP early or wait for a year before starting PrEP, and they had to stop the study early because of the high level of efficacy. So what do we know about PrEP in the real world? Well, Kaiser, Jonathan Volk, another early career investigator from UCSF and San Francisco General, published on over 650 men who have sex with men on PrEP. This was a group that had a very high rate of sexual activity, condomless sexual activity with 344 sexually transmitted infections, but no HIV infections to date. The PrEP demos project that Al Liu, who works with me, led in conjunction with sites in Miami and DC. Again, 51% of them had sexually transmitted infections on follow-up. They had 2 breakthrough infections, but both occurred more than 4 weeks or more after their last dose or last visit. But it's not perfect. We know about 2 cases of men who have sex with men who got infected when they were just on tenofovir alone, not tenofovir FTC. And they were being treated for hepatitis and they got infected. And there was one case reported at CROI this past year of someone who was consistently taking PrEP and became infected. So what we know is it's excellent, but it's not perfect. So one of the questions that gets asked is, so how long does it take to get to a protective level? And I will refer any questions to Craig Hendricks if he's here. But this is the best study that I've seen in which 21 HIV uninfected men and women were given daily TDF-FTC for 30 days. And then they used IPREX data to calculate what's the level of drug required for 90% reduction in risk. And what we have to think about is it's not just about what's the average IC90. It's really about how do you get the majority of people up to that level of protection. And so these were the data that they came up with, in which after 1 day on, 30% had achieved the IC90. So some people are going to get up there, but a lot of people are going to take longer. After a week, 89% are at that level, and after almost 2 weeks, 98% are. How long does it last for? Well, at 2 days afterwards, 80% were still at that IC90 level, fell to half by a week. So their recommendations are that PrEP for men who have sex with men be started 7 days before and continued for 28 days after exposure. I think nobody knows about the 28 days. Nobody really knows about the 7 days either, but that's probably a more conservative way of looking at it. What we also need to know is that women are different, and that vaginal tissue, rectal tissue may or may not be the same, but vaginal tissue certainly is different, and that tenofovir diphosphate both concentrates at tenfold lower in female genital tract tissue than in the rectal tissue. And female genital tract tissue have a higher rate of metabolites that compete with the NRTIs and tenofovir. On the other hand, FTC concentrates better in vaginal tissue. So, but we think that it's the tenofovir that's really the important component. And so that's why when we talk about intermittent PrEP, which I'm going to talk about in just a moment, we're really talking about that for men or for anal sex transmission. We're not talking about it for people who inject drugs, and we're not talking about it for women. Women likely need a higher rate of adherence to pre-exposure prophylaxis, 6 to 7 days per week to achieve high levels of protection. So I'm going to see if this will work, audience participation. How would you advise a serodifferent couple about condom use? And this is something that comes up all the time. So A, there's no need for condoms if the positive partner is fully virally suppressed, and there's no right answer. B, no need for condoms if HIV negative partner's on PrEP. C, you need both, but as long as you have both, if the positive partner is suppressed and the negative partner is on PrEP, then you don't need condoms. Or D, condoms are actually more effective than antiretroviral treatment or PrEP against HIV. So can I see by a show of hands, A? Some. B? Nobody's going to judge you. C? Okay, that's got the most so far. And D? Okay, and some people are there. So one of the things that I have to remind people is that condoms are not that effective. I mean, they're effective when they're efficacious when they're used regularly, but they're not used all of the time. There's a high rate of slippage and breakage, and we have evidence that PrEP is effective 86% of the time in men who have sex with men. So there's no question that condoms are important for prevention of other sexually transmitted infections. And we're seeing now ocular syphilis in HIV positives. We're seeing a real upsurge of syphilis, gonorrhea, chlamydia. All of those things really need to be screened for, treated for, and condoms will protect against that, whereas PrEP will not. But it's not, condoms are not the be-all and end-all. They don't work for a lot of people. Some people can't use them. Some people don't use them consistently. So my summary of the effectiveness data is that antiretrovirals as treatment and as PrEP are highly effective, but with some caveats. First of all, obviously, the pill doesn't work if you don't take it. You need to take the pill consistently for them to work. For treatment, you need to be sure that the partner's been consistently virally suppressed. For PrEP, data and modeling studies suggest that women need to be very adherent to PrEP, whereas men can probably get away with every other day or missing doses here and there. And that condoms are effective for preventing STIs, including HIV, but you need to use them again for them to work. And my feeling is, this is my personal editorial, and I think I left off the DPH disclaimer that I'm not speaking on behalf of the San Francisco Department of Public Health, but I think it should never be an excuse not to give PrEP. And so what I liken it to is, I never say to my patients, I'm not going to give you a statin for your cholesterol because I'm afraid you're going to eat more ice cream, you know. But there's this extra layer that gets added on to when it comes to sex. So let's talk about coverage of ART and PrEP. And I think that I may have hidden a slide that I was going to talk about. I'll just talk about it quickly now, and if it comes up, I'll just skip over it. The Ipergay study, people ask, oh no, it's here, never mind. I forget where I am. Okay, so let's talk about the cascade and get a show of hands. Where is the steepest part of the step off in the cascade? Is it in the proportion who are infected who are actually diagnosed? Is it in the proportion of those who are in care? Is it the proportion of those who are on antiretroviral treatment? Or is it the proportion of that group that's virally suppressed? So A, diagnosis. B, in care. C, on ARTs. And D, viral suppression. Okay. So we've got a pretty good split there. And what I'm going to show you is that it really is about getting and keeping people in care. That's where we've got this huge drop-off. So this is 2009 to 2012. The first bar is the proportion who are diagnosed. We're doing much better than we were before. It's about 13, 14% now who are undiagnosed. 36%, you get down to 36% when you look at people who are in care. And then most of the people who are in care are being prescribed antiretrovirals, and most of that group is virally suppressed, not all of them. But if we're going to focus on one thing, it's this huge step off and getting people into care and keeping them in care. You know, we like to pride ourselves in San Francisco about how well we're doing, and we are doing well. We've got 93% aware of their status. And we go down to 60% viral suppression. So it's twice the national rate, but it's still 60%. So 40% of people are not getting care, and our steepest drop-off is also in that arena of people not being retained in care. Unfortunately, here's where we also have racial disparities. You can see that for white men who have sex with men nationally, it's 34%. Whereas for black men who have sex with men, it's 16%. So again, this is unacceptable, and it's part of what drives the new infections, because to the extent that there is concordance in race between the two partners, if you're African American, study after study has shown that there's not an increase in sexual risk practices. In fact, often they're lower than they are in white men who have sex with men. What is probably happening is that you're more likely to come in contact with someone who is unaware of their status or who is aware of their status but not fully virally suppressed. And then I thought this was a very interesting study that comes out of Hopkins, looking at the impact of reaching the U.S. National HIV/AIDS strategy. And there are many goals, but here are three goals. Number one is a 90% serostatus awareness. Number two is 85% linkage within a month of diagnosis. And number five is 90% being in care. Now, part of this is because we are closer to goals 1 and 4, to achieving goals 1 and 4 than we are to goal 5. But this is the projected decrease in incidence and deaths by meeting the National HIV/AIDS Strategy Goal 1, Goal 4, Goal 5. So you can see that it's really all about getting people in care and adding the early linkage and adding the 90% serostatus awareness gets you some incremental gain. So we clearly need to focus on that as well. But it's really all about getting people in care and keeping them there. Now, we're trying to create a similar kind of cascade about pre-exposure prophylaxis in San Francisco. And what we know from several surveys is that about 85% of the men who have sex with men, which is, again, our highest risk population, and where 87% or something of the 86% of the new diagnoses are happening. And we have data from some other studies that suggest maybe 85% adherence. So we're going, and about 20% in these cross-sectional surveys appear to be on PrEP of sexually active men who have sex with men. What we really don't know is what's happening if they're being offered PrEP, if they want PrEP, and if they can afford PrEP. And I think that the perception of being able to afford PrEP is a huge barrier. And there are programs to get people connected to PrEP. And if you're interested in them, I would look at the Project Inform website. They've got a beautiful flow chart about what to do if you have insurance, if you don't have insurance, depending on what your income is, what's available to you in terms of services. So my summary of coverage is that we've got a long way to go. And to get adequate coverage for HIV, for high-risk persons, even when knowledge is high. But I think that it's really an issue of treatment that we've also got to focus on. That's got to be front and center. Data's lacking on the proportion of eligible patients being offered PrEP, decisions for PrEP uptake, not hypothetical but actual, and successful navigation of the system. And we're working on developing that here, and we're working with other jurisdictions to try to coordinate our efforts to measure these things. And again, we've got these same disparities: age, race, ethnicity, and I'm sure geography. So it's another thing that we need to think about. So now I'm moving on to the third category, which was adherence and persistence. These are data from Terry Blaschke that just shows, like, not taking your antiretrovirals or your pre-exposure prophylaxis is nothing new, as we all know. This is just a little over 3 months. This is the rate of discontinuation for all of these different categories of disease. They do have an HIV category. And what you can see is that people fall off both in terms of, we know about they fall off in terms of adherence, but they also fall off in just continuing to take their meds. So what happened in the San Francisco component of the demonstration project? Well, we actually did really well. At 4 weeks, 93% of those tested had protected drug levels, and it was 87% at 48 weeks. But that doesn't take into account that a lot of people dropped out. And so if you take into account people who didn't have a visit, as well as those who had subtherapeutic levels, we're down to 72%. So, and what I'll say is that in doing an early chart review, Hyman Scott, a very talented young investigator who works with me, is finding a very high rate of loss to follow-up or not getting consistent prescriptions for PrEP, and it not being charted well, whether the provider is even aware of that, or if the person really doesn't need it anymore, or they just couldn't figure out how to navigate the system. So we're actually going to be diving into that. It's about 36% who were not persisting, but it was almost double that in Black patients. So again, we've got this repeated story of these racial and ethnic disparities that we need to address. So people say, but why would you want to go on a daily pill just to prevent yourself from having to go on a daily pill? But we know that HIV causes disease even with full viral suppression. Things are much better than they ever have been, but they're still bad, and we don't think that people need lifelong PrEP. So we talk about this seasons of risk, and these are data from the MAX cohort longitudinally, and almost two-thirds were in the low-risk group. But you've got almost a quarter who are in this moderate risk group. The red is the high-risk interval, and the blue is a low-risk interval or no-risk interval. And what you can see is that for many, there's a 14% who look like they need to be on PrEP through the 16 cycles or 8 years. But these are some examples of the mid-level group. And you can see that there are periods of time when they might really benefit from PrEP, but it doesn't necessarily need to be forever. So here's what I was looking for, and of course unfortunately the font is not showing, but it's the IPERGAY study from the ANRS. And what they did was they said to men, you don't need to take PrEP all the time. You could just take 2 tablets within 2 to 24 hours before, 1 tablet 24 hours after sex, and another tablet 24 hours after that. Got it? And I guess this is supposed to be the period that you're having sex, and I won't comment on the diagram other than it looks like they're happy. So 2 pills before, 1 pill a day after that, 1 pill a day after that. And what they found was that they got an 86% reduction in new infections, which was phenomenal. It was the same as the PROUD study. So maybe this does work. The issue is that on average, they had at least 1 sexual encounter a week, which meant they were taking 4 pills a week, which is the same for men who have sex with men as taking a daily pill, probably in terms of effectiveness. So we don't yet really know how this works. And what we did was we looked at, do men plan for their anal sex? So we asked over 1,000 men on an online survey, did you plan your last anal sex episode? And it was about 50-50. But then we asked, well, when did you plan it? And minutes to hours probably isn't going to cut it. And so, but that can be considered planning. But I think it's really hard for people to necessarily know. Now, there are periods of time when people do know. Like, I hear patients say, doc, I don't get out much. I work really hard. I'm really busy. But when I go on vacation, I really go on vacation. So it's something to think about when there really are clear, known periods of risk. So let's talk about intermittent PrEP, and I would say that it's not for everyone. So this is another more recent study of over 3,000 MSM. Half had unplanned condomless anal sex in the past 3 months. So similar to what we had shown previously. This is not called this, I just call it the Hope Springs Eternal Study. What they did was they took 92 HIV-negative men who had sex with men and asked them each day, do you think you're going to have sex tomorrow? Do you think you're going to have sex tomorrow? And they were very good at predicting when they absolutely wouldn't have sex, but they weren't very good at predicting when they would. So a lot of times they said they were going to and they didn't. That's why I called it the Hope Springs Eternal Study. But so their recommendation was skip your daily dose only if there's a 0% chance that you'll have sex tomorrow. And then, as I said, there's this vacation sex or malaria prophylaxis 2.0 that you could use PrEP in that way. And I think it's actually really important that we talk to our HIV-negative patients who may be at risk to find out, are there periods of time when you know that you may be at higher risk, because we want to get you on PrEP before that happens and continue through that period of risk. And this is a study of over 7,000 men who have sex with men, and 26% said that they had new partners and condomless anal sex while on vacation. So, summary of adherence and persistence, there's a substantial drop-off in meds for most use, and that's true particularly for preventive strategies. There's high persistence in some subgroups, but much lower in others, and we do need to reassess risk to figure out when, for pre-exposure prophylaxis, discontinuation is appropriate. For treatment, people should be on consistently. Periodic PrEP is going to be useful for some, but not all. And pericoital dosing has a lot of challenges. It's about planning, it's about adherence, and it's about pharmacodynamics. Particularly those post-dose exposures can be very difficult to adhere to. People are otherwise engaged and not necessarily thinking about it. So I'm going to put all of this together. This was from a modeling study in men who have sex with men in the UK. And in this, the question is, can we synergize by using treatment and prevention? Now that we've got highly effective treatment and highly effective prevention, what should be their relative contributions? And they look like they might contribute approximately equally in this modeling study in incidence. But what was sort of interesting to me was, rather than focus on getting up to that 100% efficacy, it's more important to get good coverage according to this model. And so here's what we have is, this is the, if infections were status quo, this would be the number of new infections. So anything below that are the number averted. Each of these lines shows if PrEP were 20% effective, 44% effective, 60% effective. And what you can see is that the space between the lines at the low levels of coverage is not really great. What you really need to do is move this way on the curves to be able to get more infections averted. And you can see here that 25% coverage at 100% effectiveness is actually equivalent to only 20% effectiveness if you got 75% coverage. So what you really need to do is make sure that you're getting PrEP out to individuals who need it. So I'm going to end by talking about new agents and new formulations, so new kinds of approaches. Someone had asked about nanoparticles. So this is one of the approaches, are long-acting antiretrovirals, and this is for cabotegravir, which is similar to dolutegravir. But, for a lot of people say, oh, but the injectable's right around the corner, and it's going to be licensed any day now. It's not going to be licensed for pre-exposure prophylaxis any day now. We're about to launch an efficacy study, but there are some good things, some bad things, and some potentially ugly things. So the good thing is that it's got a long half-life, so you get consistent levels for at least 2 months, so that may be helpful with adherence. The bad news is that if you have a bad reaction to it, it can't be dialyzed off, so you need to have this oral phase run in because you could have it present for up to a year. And the potentially ugly thing is that if we look at long-acting injectables for contraceptives globally and in the United States, it's only about 50% who come back at 6 months and they're still on this long-acting injectable. So just because it's an injectable doesn't mean that people are going to be adherent. And in this case, if you miss doses, you're going to get to a subtherapeutic. The good thing about TDF-FTC is it works when you take it. When you don't take it, it doesn't work, but you don't get resistance. It's in that middle area where if you're at a subtherapeutic level for a long period of time, or you restart PrEP after you've become infected, that's when you'll develop resistance. In this situation, my concern is that you're going to have these non-protective levels that may generate resistance. So I think there are other methods of delivering long-acting agents like implants that will also be along, but we'll have a lot to learn from this particular approach. So I'm going to end with my favorite modality. Not that you're supposed to, all of my children are my favorites, but this is a quote from Stanley Plotkin, and it's just about with the exception of safe water, no other modalities had such a major effect on mortality reduction and population growth. vaccines can really do a tremendous amount. We haven't had a vaccine. This is the first evidence of a protective effect, and that was that little lone green circle on that efficacy chart. The good news here is that it did look like there might be 60% reduction very early. And as the immune response waned, so did the efficacy, and it was 31% by the end of the study. The other good news is that we finally have a correlate that may be a correlate of protection. So among the people who got the vaccine, those who had antibody to this particular region of the HIV envelope were more likely to be protected. There was a 40% reduction in infections in people who had this antibody. There was actually an increase in risk if you had IgA versus if you didn't have IgA. And what they found was that it looks like IgA might have been interfering with the protective effects, including the avidity of IgG, antibody-dependent cytotoxic, cellular cytotoxicity, and other non-neutralizing functions of antibodies. So we have a lot more to learn, but again, the good thing, what made this seem even more plausible was that there was a sieve analysis done in which you're looking to see what infections get through in the vaccine group and in the placebo group, because the problem with this kind of analysis is that you're looking at only among the people who got the vaccine, and so there's no randomization there. But you can look at the randomization when you look at, okay, what got through, which viruses got through in the vaccine group versus which ones got through in the placebo group. And what was found was that the HIV that matched the vaccine at those same correlate, at that same location, was much less likely to infect vaccinees than it was to infect placebo recipients. So the placebo recipients had much bigger holes and these blue pieces got through. The vaccine group didn't get those to the same extent. So we think we may have a correlate, which is really important. And what I'll say is that it's many years later now, but we finally have the products made of the vaccines that were protective in that Thai trial that are going to be tested in South Africa. And that trial will be launched in the next several months. We're also testing antibody-mediated prevention. And we're using monoclonals to see if we can prevent new infections. It's called the AMP study. There is a long history of using antibodies to prevent viral infections, and in particular against RSV, we've got monoclonals. A lot of the earlier studies were really about immune globulin, gamma globulin. And I understand that John Mascola may have spoken here previously, I don't know, but maybe it was at a different location. But just down the street at the Vaccine Research Center at NIH, they have developed a monoclonal antibody that is based on an antibody that was discovered in a long-term non-progressor, an elite controller. And you can't really see it, I think, on this, but the green and the purple are blocking the CD4 binding site. So the CD4 binding site is where HIV is going to latch on to the cell. And if you've got this big bulky thing blocking it, then you can't necessarily attach to the cell. And what you can see is that there is great broad neutralizing antibody against multiple clades. So this is a study, the AMP study is happening in North and South America, in men who have sex with men and transgender people who have sex with men, and in sub-Saharan Africa, Southern Africa, and East Africa in heterosexual, or in women. So my final two slides, how do we make progress in prevention? I think about the model of ALL, acute lymphocytic leukemia in children. In 1964, the 5-year survival rate was 3%. Once the first major breakthrough was made, then there could be incremental gain. So I feel like we're there now with many of our approaches and with vaccines as well, but we just don't always know where they're going to come from and when they're going to come. So 10 years before the licensed highly effective polio vaccine, one of the leading investigators said the part played by acquired immunity to poliomyelitis is completely uncertain, and the practical problem of preventing infantile paralysis has not been solved. It's doubtful whether it will ever be solved. So that was just 10 years before we had a licensed, highly effective vaccine. So I think we don't know where we are in that tunnel, but I think we're starting to see the light. And so I'll end with this Yogi Berra quote: "If you don't know where you're going, you might wind up someplace else." And I think we have with HIV. We didn't, at the very beginning, we didn't know where we were going. And we've learned so much about so many things that apply to so many diseases. So sometimes it's a good thing to not know exactly where you're going. And I just want to thank those who came before me, and a special shout out to Alvaro Munoz, who was the kindest person ever when he asked me a question and I was completely unprepared, unable to answer it in front of thousands of people at the International AIDS Conference. He came up and spoke to me afterwards and was so kind and lovely. To my peers, including Dick and Chris Beyer, and to those I learned from the most, who are the early career investigators who are doing such important work. And I just want to thank Risha, who was here, and many of the other early career investigators with whom I've had the pleasure of working. So thank you.
Thank you very much, Susan. That's great, and we have time for questions. And I'm going to ask one because I'm intrigued when I hear this PrEP versus condom discussion. So when we were kids in San Francisco in the early '80s, rectal gonorrhea went from 1,000 cases a year to none.
Yeah.
And HIV sero incidence went from 15% per year to essentially zero with condoms.
Yes.
And now we don't see that anymore. And I think many people would agree it's the context that we don't see people dying left, right, and center of pneumocystis. And I think the context for PrEP is no different than the context for condoms. And how do you think that PrEP will roll out in the setting of lack of motivation because of lack of AIDS deaths?
So I do think condoms are important. They're important for preventing infection, but I think people use them as a crutch sometimes in talking with their patients, with their friends. There's a whole moralistic component that goes along with it. And we know that some people just either can't or don't use condoms, or their partners won't use condoms. So I think PrEP is a whole different thing. The reason for not using condoms is that it interferes with pleasure. PrEP doesn't interfere with pleasure for the most part. The first couple weeks, maybe you're not feeling so great, but then after you get through that period of time, I think it's revolutionized prevention. Now, it's not for everyone, which is why we're looking at vaginal rings and long-acting injectables and implants and all kinds of other things. But I think it has the power to really revolutionize prevention, with condoms and the caution that PrEP is not going to protect against sexually transmitted infections, and that we really need to deal with that in HIV-positive patients as well, because that's where we're seeing some of these really bad outcomes, particularly with syphilis. The other thing that PrEP does is you need to test people every 3 months for HIV and STIs. And so we're picking up many more cases of syphilis, gonorrhea, chlamydia, often asymptomatic, and that gives us the opportunity to actually do more prevention work.
Thank you for your talk. In relationship to the treatment cascade, could you outline some of the known determinants of that and whether neuropsychiatric disease plays a role, which we assume it should?
So I'll repeat the question. The question was, what do we know about what drives the cascade? And does neuropsychiatric disease affect it? And I would say absolutely, there's no question. Our most difficult and most vulnerable patients often have mental health issues, substance use issues. They may also have neurocognitive deficits, in part because of untreated HIV. So there's no question that is, we think that there are 3 things in particular driving this. It's mental health issues, it's substance use issues, and it's housing, homelessness, economic factors. And then there's the stigma, and I didn't get to talk much about stigma because I think we're still having questions about how to address stigma. But it's much better than in the old days when we were training, when some of the residents wouldn't pre-round on their AIDS patients. Not Dick. He was always a beacon of light. But he was. That wasn't sarcastic. I can be sarcastic, but that wasn't sarcastic. But I think we've got to deal with those structural factors if we're going to really address the epidemic.
Susan, so we talked a little bit about this last night, but you've been monitoring the rates of rectal gonorrhea, syphilis, and chlamydia, and so forth in the population since the 1980s, and you just alluded to these upswings and downswings. So when PrEP was introduced, and what the uptake of PrEP is, can you correlate any changes in the STDs? I mean, you mentioning that you're screening for them a little bit more often will probably affect that. But has the rate of STIs increased with the increase in PrEP? And is a message about concomitant condom use getting through to prevent the STIs among the PrEP users?
So Tom's question, I think probably most of you were able to hear it, but there's the video, they asked me to repeat them, is what's the temporal relationship of PrEP uptake and our increase in sexually transmitted infections? The huge rise in sexually transmitted infections started way before PrEP. It started probably, again, with treatment and people being less concerned about HIV, and also seroadaptive behaviors. So people who are positive in particular saying, I can have sex with another positive person and not need to worry about condoms because we're not going to get HIV infected. We're already both HIV infected. So I don't doubt that PrEP may make things worse, but we've always had this high rate of sexually transmitted infections. The aberration was around the AIDS epidemic when people started using condoms.
I was wondering if your thoughts are the same for weekly pills or bi-weekly pills as the injectable that you described.
Yeah, so the question was about what about weekly or biweekly pills compared to the injectables. I do have a concern about the long-acting injectables just because we've got to figure out what we're going to do about that tail. It may be that ultimately we can incorporate vaccines with long-acting injectables, and you give the vaccination and you start people on a long-acting injectable, and by the time they stop the long-acting injectable, they've got their immunity. We're not anywhere near that yet. I think the problem with weekly pills and biweekly pills is that people forget to take them. So there's forgiveness with TDF-FTC if you're a man. If you miss a pill here and there, it doesn't matter. If you're a woman, it probably does. But if you're taking it every week and then you miss a pill or two, then you're in trouble. And I think that the issue is if you go for a period of time, and it may be just a week, without any TDF-FTC, and then you have an exposure and you're unlucky enough to become infected, and then you restart TDF-FTC, then you're going to develop resistance.
I'm wondering about representation, and I saw that you brought up racial disparities in PrEP. The data I'm working with indicated there are big disparities in PrEP awareness by race and ethnicity. And I'm wondering how you think we should implement PrEP and roll it out so that we don't exacerbate existing disparities in HIV.
Okay, and I think I'm being signaled that this might be the last question, which is fine. So the question was about racial and ethnic disparities in PrEP, and how do we address those so that we don't take this highly effective tool and make disparities worse rather than better. And I don't think there's a single answer. I do think that we have to look at ourselves in the healthcare system and think about and learn about and ask what we're doing to make healthcare settings an unwelcome place for many people. And I think that that's a big piece of, it's about building relationships with people who want to come and see us because we're actually doing something for them rather than to them. What I'll say is that at our city clinic, in our prep demo project, we had a very low proportion of African Americans, a higher proportion of Latinos, but not in keeping with our new infections. Now, in our DPH clinics and in our city clinic, we're pretty much matching the demographics of our new infections. We still have work to do. We're still a little bit, there still are some disparities, and we still need to get to young people. And what I'm very concerned about is the under 18 group, because that's, as we heard earlier this morning, that's a group that's very vulnerable and often doesn't have access to PrEP, may not know about PrEP, and may be seeing a pediatrician who doesn't know about PrEP. So we're really trying to get the word about PrEP out to adolescent medicine doctors and pediatricians.
Why don't
Oh.
you come up and ask the last question?
Oh, you were signaling to ask a question. I thought you were signaling to like, "Arr."
So actually, I wanted to ask you about AMP, because of course you've been an investigator in both the PTN and the VTN, leader in both. And, you know, I get asked and also don't have a good answer myself to what extent there is a scientific rationale for this as an experiment in some ways, or what realistically is the potential preventive use of
Right.
an infusion-based approach.
Right. So what I didn't mention were the details of the AMP study, and that basically people have to get a bi-monthly IV infusion. I will say parenthetically that we have people lined up around the block. We can't handle the burden, the volume of patients that are coming in and the speed that they would like to enroll. And I think a big piece of that is that there's no vaccine-induced seropositivity. So you give a vaccine, and people may develop antibodies that will trigger a positive antibody test, and it could be for many years. Whereas in this case, you're infusing these antibodies, but they're cleared in several months, and so you don't have VISP after that. So that's a vaccine-induced seropositivity, so that's a good thing. Is this a product that we're ready to license as soon as if we found it was highly effective? No. But it's going to give us a lot of important information about what we might do. So there are versions of this drug, of this monoclonal antibody, that are longer acting, that could be like a long-acting injectable, that you wouldn't have the same problem that you have with the long-acting antiretroviral injectables in terms of resistance. It also is telling us, does this approach work? Everybody's been working on neutralizing antibodies. And I know, because I was the principal investigator of the STEP study, we were all looking for cytotoxic T lymphocytes, and we finally had a vaccine that had great CTLs. And not only did it not work, but in a subgroup of men, it may have increased their risk of HIV acquisition. So that was really awful, and it turned the entire field almost 180 degrees. So we need to know, do neutralizing antibodies actually protect in people? We know they work in monkeys, but we don't know if they work in people, and we don't know what level to shoot for. So this is an early generation monoclonal, and it's likely that we'll need multiple monoclonals together in a group, but it's going to tell us, does this work, how much is needed, and is this a product that we could move towards a component of an effective vaccine? It's a passive immunotherapy rather than an active immunotherapy, and it could lead us to an active approach as well.
Well, that was a great answer, and it was a wonderful talk. And I'd like to now close the session. And just before I ask you to join me in thanking Susan Buchbinder again, just to invite you all to lunch back in Sheldon where we were this morning, Vinestone, and then to continue for the rest of the afternoon. We have several more young investigator talks for the CFAR. But Susan, thank you so very much.